this computer. Also, I just sent out the allergic reactions lecture. So you have 7 days from today to complete that if you weren't in the class last time for that lecture. Let's see. So recording. Yeah, all right. So anatomy and physiology, so you have abdominal anatomy. So obviously it contains many organs, both hollow and solid. Solid organs just means that they're more vascular. Hollow organs are less vascular. So the hollow organs would bleed out more as opposed to your hollow organs. Can cause confusion when determining the cause of abdominal emergencies. And that's because there's so much going on in that area that you can't really pinpoint where that pain is actually coming from. And that's what makes it so difficult. Thorough patient assessment is key. Specific diagnosis may not be necessary. Treatment is the same for most conditions. So like I said, because you are out in the field, no EMT or paramedic could really pinpoint and make sure that they know exactly what's going on with the patient. So therefore, the priority is to treat for shock for these patients. We do what we can given the situation, but ultimately, like any other patient, they need definitive care, and that definitive care is taking them to the hospital. So region between, so the abdomen is your stomach. That's all that is. Abdomen equals stomach, and it's right below your diaphragm and your pelvis. Your diaphragm is that muscle that contracts downward to allow air to come into your lungs, right? So the diaphragm is right below your chest and right above your stomach. It's that dividing point between the stomach and the chest. And the pelvis follows after your stomach. All right, so as far as what's in this area, which system? So digestive system, reproductive system, endocrine system, and regulatory system. So this is what's being affected or could be affected if your patient has some kind of damage to the abdomen. So the biggest takeaway from this picture that I want you guys to understand and get is that most of your solid organs are going to be on the top portion of the stomach. They're going to be on the epigastric area of the stomach. Most of your hollow organs are found right here. Your intestines, your stomach falls kind of in both areas. But the reason that this matters is because if the pain is epigastric and you have some bleeding up here, there's a potential for a good amount of blood loss because of all these solid organs. Your liver is very vascular, has a lot of blood. If one of these ribs were to break and puncture a liver, your patient could bleed out quite a bit. Now, most patients, you're gonna not even notice that there's distension or discoloration in the abdomen because of bleeding out until they lose approximately 2 to 3 liters of blood. At that point, it's real significant because if your patient has lost 2 to 3 liters of blood, they've just lost about half of their volume. And that half of the volume is out of their veins and their arteries and in the stomach outside of the system. So it's not going to be of any use to your patient. And that's why it's a big deal. So it is divided into 4 sections, right upper, lower upper, right lower, left lower. Epigastric region, and here is a visual of the quadrants. It's good to remember them, especially when you're talking to a doctor or a nurse. You talk in medical terminology when we're out in the field, out on the job. So knowing your quadrants is very, very important. And here, your diaphragm is right here. So the diaphragm is the division between, it divides the stomach, the abdomen from the chest, the thoracic cavity. See, abdominal organs. All right, so the peritoneum. I'm not sure if I mentioned this, but I'm pretty. I think I did. The peritoneum is the skin of the organs. So every single organ in your body has like an extra membrane. So it has a layer that covers it. Just like how we have skin, every organ in your body also has its own version of skin. That's what I'm trying to say. It's not actual skin. It's a membrane. A membrane is just some flesh, some tissue that covers something, like our skin. That would be a membrane. Uh, so that's what the peritoneum is. The peritoneum is a continuous membrane, and what it does is that um, it covers the inside of your stomach, and it lines up the inside front of your stomach, and then it kind of folds on itself and comes back around and individually encapsulates other organs within your stomach. I'm not sure if that makes sense, but let me see if I could go back to this one. All right, so let's say that your peritoneum, that membrane, will line up the front of your stomach. So it lines up the front of your stomach. So we'll say this is the front, right? It's not a good picture for this. Let me see if I can find a better one actually, because it doesn't. Oh, perfect. Here we go. Here we go. Okay. So the peritoneum will line the inside of your stomach. So if you're in here, let's say you like, I shrunk you and I just stuck you right here. You're right here. And you're looking this way. You're looking outward towards the belly button. If you're looking outwards to the belly button, that membrane will come all the way down and cover the front, the inside of the front of the stomach, and then will overlap, come back around on itself, and individually wrap each organ. All right, not each organ, but the ones that it does. And that's what it does. It's a membrane of the organs. It's just a layer of protection. So you have the parietal peritoneum and the visceral peritoneum. So the other example that I use as far as membranes is the membrane of the lungs. And those that don't remember, that one is called the pleura. So the membrane that covers the organs in your abdomen and your stomach itself is called the peritoneum. All right. The membrane that covers the lungs is called the pleura. I'm not sure if you guys remember, but the lungs have two layers of membrane. One that covers the lungs completely, and then you have one over the entire lungs, over both lungs, that encapsulates both lungs. So it has two membranes. One membrane encapsulates each lung individually, and the other one wraps both of them together. Parietal peritoneum is the one that's on the outside. Just like parietal pleura is the outside, the top membrane, and visceral peritoneum is the membrane that is on the bottom that's actually encapsulating the organs. But the thing is that there really aren't two membranes. It's just one continuous membrane, but because it overlaps on itself and it folds and goes back around, that's why we categorize it into two different categories, parietal and visceral. So like I said, this membrane encloses most enclosed within organs and of the abdomen, most enclosed within parietal peritoneum. A few lie extraperitoneal space outside of the peritoneum, and these are the ones that do lie outside of the peritoneum. If you do not know this, I would write this down. You will see a question regarding this in one way or another on your NREMT, because I do remember seeing this question, a question that refers or regards to this for both the EMT and advanced EMT test that I took. So go ahead and write this down. It's a quick little note. It'll help you out. So I'll give you guys a few seconds for that. All right, go ahead and keep moving on. So it's a different angle. Shows you where everything's at. Again, solid organs are on the top. Hollow organs are on the bottom for the most part. Abdominal pain and discomfort. All right. See, visceral pain. So, like it says here, originates from the organs within the abdomen. Fewer nerve endings allow for only diffuse sensation of pain. So this means that you're not really going to be able to pinpoint the actual pain and where it's coming from because of the fact that there are not that many nerve endings. So if there are not that many nerve endings, there's not that much sensation. And that's why there's difficulty kind of pinpointing where the issue is in the abdomen, frequently described as dull or achy pain. So colic, intermittent pain. So I'd write that down if you don't know it. Colic equals intermittent pain, may result from distension. Distension just means that it's getting bigger, it's being stretched out. Stretching out is probably the best way I can put it for distension. So you think of the picture, I mean, the stomach just kind of bulging out, that's distension and or contraction. We all know what that is already, of hollow organs. So pretty much the dilation or distension and contraction of the hollow organs will cause pain. That pain is due to irritation of some sort, right? And that could be many different things. Persistent or constant pain. All right, parietal pain. I'd write this down too. I'm gonna give you guys a few seconds as I'm talking about this. So it originates from the parietal peritoneum. The parietal peritoneum again is that membrane that's on the top, on the outside. Many nerve endings allow for specific, efficient sensation of the pain. Again, this is not. These are not nerves that are going to your organ specifically. These nerves are attached to the membrane that covers the organs themselves. So if they have parietal pain because it's coming from the parietal peritoneum, then it's frequently going to be sharp pain. So sharp is an indication of parietal pain. Also, if the patient can pinpoint pretty well where the pain's at, then we're going more towards it might be a parietal issue. Some kind of irritation, maybe a tear. We're not sure exactly what it is, obviously, but it guides you more towards, all right, we know that it might not be an organ issue, it might be a membrane issue. Pain is often severe, constant, and localized to a specific area. So tearing pain, we think about, let's see, James, you still there? James?
Yeah.
All right, what can you tell me about the aorta?
The main artery.
Yes, that's the main artery good that comes from your heart from the left side and feeds the rest of your body with blood and oxygen. Well, good. Uh, a tearing pain, a tearing pain in the abdomen, we're always gonna just red flag and put an abdominal aneurysm or aortic abdominal aneurysm because it's in the abdomen region, so it's gonna be abdominal aortic aneurysm that possibly bursted. So that will tear. So it's gonna feel like a tearing sensation, and that's because the vessel is tearing. The big vessel that feeds your body with blood is tearing. From my understanding, most of these patients don't really survive. Let's see. I've only had one patient that had an aneurysm burst, an aortic aneurysm, but I was just transporting him from one. I forgot why he was at the hospital, but he had to go to a different hospital for surgery, I think, for that. And I was just a transport from the one hospital to another, but he was the one that had that. I think he had a stroke and an abdominal aneurysm tearing at the same time. It was kind of weird, but All right, so we talked about that. Let me see. I'm gonna go ahead and put on a video because I know I I looked up a few videos online, but I forgot exactly for which section. So I'm gonna look them up right now and see if I already passed one. Uh, mm, what happens? Drink nostril poison, experiencing food poisoning. No, that's not it either. See alcohol, activated charcoal, hernia. I guess I only had one for the abdomen reason. All right. Oh well. I guess most of them are um for the next lecture. So let me go back. All right. Abdominal conditions. Let's take another 10-minute break, guys. And we'll get back to it. So 8:30, be back on here, okay? All right, here we go. I think we're about halfway with this chapter. All right, infections of the appendix. So it's gonna be on the right lower quadrant because that's where your appendix is actually found. So what happens to your appendix, in case you guys are curious, what happens is that the appendix, the only thing that we know so far is that it collects bacteria. And from what I understand is that it collects bacteria kind of like to store the bacteria, and then it helps combat against other issues in your digestive system. I just like broadly know what it does. I don't know anything specific. But because of that collection of bacteria and other stuff, sometimes the appendix, it'll get clogged. All right, it'll get clogged, and when it gets clogged, that's when it gets inflamed, and that's when you have appendicitis. It's because it's clogged. So a few things you're gonna have. You're definitely gonna be nauseous, and you might be throwing up. You might not. I know that when I had this, because I did have appendicitis, and they had to take it out when I was smaller, I was definitely vomiting, but it took a while before I was vomiting from when the pain started. See, pain often initially referred to umbilicus, a region followed by persistent right lower quadrant pain. That sounds about right. Rupture, sudden severe increase in pain. So the reason for the pain, oh, it says right here, is because of the peritoneum. So because peritoneum, parietal peritoneum, yeah, because the peritoneum, that membrane, whenever that bacteria or whatever was inside your appendix bursts, that is going to touch the peritoneum and it's going to irritate it. And that's when you get peritonitis. Remember, itis just means an inflammation of something. Peritonitis means that the membrane is inflamed, and it's inflamed, and it's because of the irritation from the bacteria and everything else that ruptured out of your appendix. And just talked about what that was, so I'm not gonna cover it really. The only other thing you should know about peritonitis, and this is in regards to like a rupture. So for example, if the appendix ruptured and all those the fluid that was in there went on the peritoneum, when that patient is moved around, they're gonna be in severe pain when they are moving around, and that's because that fluid that's the fluid bacteria that was in the appendix is now kind of just slushing around inside the stomach and just going back and forth across the peritoneum, and that causes extreme pain for your patients. So if your patient has pain when you're moving them, it's extreme pain in the abdomen, it's a good chance that something ruptured in the abdomen and spilled over onto the peritoneum and is now irritating and causing all that pain. And that's where it's coming from. That's just a possibility. Like I said, we don't really know what's going on with abdomen injuries. Our best bet is to take them to the hospital and take them there fast. Sorry, give me a second. I'm gonna charge my laptop. There we go. All right. All right. So cholecystis. I can't even say that. So often caused by blockage of its outlets by gallstones. Symptoms often worsened by ingesting. We talked about this already. This was the gallbladder. I think that it was a test question. So we talked about this already. Pancreatitis, if that just means that the pancreas is inflamed. There are different conditions, different issues that will cause the pancreas to inflame and get irritated. Because it is on the top portion of the stomach, you're gonna have epigastric pain. Remember, epi means above, gastric, we're talking about the stomach or the GI system. All right, so epigastric pain above the stomach, on top of the stomach, often referred to back and or shoulder pain. So with hemorrhage, when you're bleeding inside your GI tract, you can have upper GI bleed or lower GI bleed. So whenever you have upper GI bleed, that means you're bleeding on the top portion of your esophagus. So your esophagus is that tube that runs on the backside of your trachea. So if the top portion of that esophagus has a tear somewhere, or ulcer, and it's bleeding, that blood can come out through your mouth, obviously. If it's lower on the esophagus, you can regurgitate that blood, so it's gonna go down into your stomach with whatever else is going in down in there. It's gonna leak into your stomach. Well, we cannot digest raw blood. So if we digest raw blood, it's going to kind of halfway get processed, and then your body, your stomach is going to not accept it and reject that blood, and you will vomit it. So if it is a lower GI bleed, what you'll see is your patient might be vomiting like coffee grounds. It's like a coffee ground substance. It looks brown and disgusting, and I'm not sure how it smells. I've never seen it, but it'll be a dark brown-like, grainy-like vomit. That means your patient most likely has a bleed in the esophagus, and that blood is going down into the stomach, and it's being half processed because your body cannot digest raw blood and thrown back out because you can't process that. Signs and symptoms. Okay, so if you have a GI bleed down your GI tract, below your stomach, on the lower portion of your stomach, what could happen is that it will run down through your GI tract, down through your intestines, your small intestines and your large intestine, and it will come out as dark stool. So if it's an upper GI bleed, your patient will reject that blood, and you will vomit it, and it'll be like a black coffee ground like vomit. Or if it's actually processed through your GI tract, it's gonna come out as black stool. So what I'm gonna do is I'm gonna wait on here for a few seconds and let you guys go ahead and just take some notes on this. It's pretty important. All right, I'm gonna skip these abdominal aortic aneurysm slides only because I know I talked about it so much in lecture and even when we came back online. So I'm gonna go ahead and skip this and get straight to a hernia. So all a hernia is really, it's a tear in the muscles. So you'll see this a lot in the stomach. So there might be a tear in the muscles of the abdomen, and what that does is that since there's a tear in the muscles, your intestines could protrude out, could stick out out of your stomach, but it's still covered with skin, obviously, because the skin is still intact, but the muscles aren't there. So the thick layer of muscles will open up and leave a little pathway for your intestines to be pushed out, because all the weight inside your abdomen, so a little part can be protruding out. Let's see, maybe precipitated by heavy lifting, may cause strangulation of tissue or bowel obstruction. may require surgical repair. And for this, I did find a video. So some signs and symptoms: sudden onset of abdominal pain, and that's from the abdominal pain may be coming from, well, one, the tear, the actual tear itself, but also from your intestines bulging out, and that pressure on your intestines themselves could be causing the pain. Palpation mass or a lump on the abdominal wall. And so let me go ahead and share that video with you guys real quick. I think it's a hernia. Let me know if you guys can't hear it.
Yeah, there's no sound.
All right, awesome. Thanks. Let me go ahead and fix that for you guys. Stop sharing. Okay. There we go.
Your doctor has told you that you have a hernia, but what does that actually mean? In general terms, we can say that a hernia occurs when the layers that make up the abdominal wall weaken. In other words, the fabric of muscle and other tissues which protect the gut develops a defect or weakness. Through that defect, the peritoneum and perhaps other organs push their way outward, forming a lump which can be felt and sometimes seen protruding from the abdomen. During normal childhood development, boys' testes slowly descend from the interior of the abdomen down into the scrotum. They pass through the abdominal wall by way of a natural passageway called the inguinal canal. In men, the inguinal canal contains blood vessels that supply the testes as well as the vessel that carries sperm to the penis. Hernias that occur due to a weakness in the abdominal wall at the inguinal canal are called inguinal hernias. And not surprisingly, men are 25 times more likely than women to experience a hernia in this area. Some inguinal hernias press directly through the floor of the inguinal canal. Others follow the route taken by the blood vessels that supply the testes. This kind of hernia, called an indirect hernia, can even push all the way into the scrotum. If those organs cannot slide easily back into the abdomen, the hernia is said to be irreducible. Irreducible hernias are often painful and can lead to complications. For example, if the intestine becomes trapped in the hernia sac, it is said to be incarcerated. If the neck of the hernia sac actually pinches off the supply of blood to those organs, which have become trapped inside, the hernia is said to be strangulated. On the day of your operation, you will be asked to put on a surgical gown. You may receive a sedative.
So that's what a hernia is, pretty much. You guys can't do anything about that as EMTs, but obviously you have to understand what you're looking at so you can communicate that to the doctor or the nurse on shift. So I would write down renal colic equals kidney stones. Kidney stones, like the layman term that we use for renal colic. And the biggest thing here is flank pain. So this flank pain here, if you guys see this on the NREMT, and there's no other indication for anything else, flank pain, just in a medical setting, you go ahead and just red flag kidney stones, okay? And if that's one of the answers, there's a good chance it's gonna be this, as long as there's nothing else going on with the patient but flank pain. I highly recommend that you write down flank pain equals possible kidney stones. And he's like, get that in your brain. It'll help you out with the question for sure. All right, so cardiac involvement. So because the nerve endings, sometimes the nerves that connect to the heart, they also connect to other parts of the body. And as those nerve endings go back into your spine, they'll connect, and those messages that travel to your brain will sometimes crisscross each other. And I hope that makes sense. I'm trying to make it as simple as possible. And if you have some kind of cardiac issue, your patient might feel it in your epigastric or in the middle of their back. Now, for some reason, from my understanding and my experience, most of your patients that are having like a heart attack or some kind of cardiac issue where they have epigastric pain, but it's cardiac in nature, usually it tends to be a female. Not sure why that is, but that's just a good little side note to have. I'm gonna go ahead and see what this video is about.
Can
you guys see that or no? The video? I'm gonna switch sharing just to be safe. All right, here we go.
Common location of abdominal aortic aneurysm. The most common location of abdominal aortic aneurysm is between the renal and iliac arteries. An aneurysm is luminal dilatation caused by degenerative changes in the aortic wall, leading to an increased vessel diameter and bulging of the abdominal aorta. Eventually, the degenerative changes may lead to rupture of the aneurysm.
Oh, that was pretty simple.
The most common location.
Assessment and care of abdominal pain or discomfort. History specific to females. So these are questions that obviously we would want to ask females because it could be a menstrual cycle issue. It might not be anything else. So, where are you in your menstrual cycle? They might be a little late. They might be a little early. That affects it. Is your period late? Do you have bleeding from the vagina that is not menstrual bleeding? And the reason you have to ask them is because patients won't always tell you everything, and or patients can't really link things up together because they haven't been trained, so they don't know any better, obviously. So you'd want to go ahead and ask the questions because you know what's going on. You know different possibilities that could be causing that pain. Have you had this pain before? All these questions. Sample history, again, this is a mnemonic that we use for every single patient, regardless of what the issue is. If they can answer these questions, we want to know them. And that's because it's going to help long-term with patient care at the hospital. So if they're allergic to any medications, we have to know that. If they're taking any medications, not only is that good to know for the hospital, but it also helps us paint a picture of the patient and how they are in general. Obviously, pertinent past history. So pertinent meaning that it pertains to the actual medical call that you are in at the moment. So if your patient has chest pain, we're only going to ask questions that pertain to the thoracic cavity, whatever's inside that chest, the lungs, the heart, things like that. The last oral intake, this is good for the hospital, but it's also good because what if what they ate was the issue? What if that's causing the emergency? And then just general events of what happened right before the medical issue started occurring. See, geriatric. So with geriatrics means that's your older population. Now, I believe it's from 60 or 65 years of age and above. So you just look that up, but we do have a chapter on it that's coming up. But geriatric just means that's for your elderly population. And the side note is telling you that if your patient has pain, really pay attention to that pain, because as you get older, your nerve endings are not stimulated as easy. So if the stimulation is not as easy on your elderly population, then they won't feel pain as easily as a 30-year-old or a 20-year-old. So if they actually feel pain, pay attention, because it could be a serious issue because of the nerve endings being so deteriorated. More serious causes of abdominal pain. Again, like for example, the abdominal aortic aneurysm that is bursting, that tearing pain. If you have a tearing pain in an elderly person, I would be concerned that it could be a life, like it says here, a life threat from a tear in the aortic, that's in the abdomen area. See physical examination, distension, we talked about that. That's the stomach bulging out. Discoloration could be like bruising. Protrusions, it's something that's like sticking out. Every time you see palpations, think of touching. Palpation means that you're touching something, you're feeling something. Use fingertips, and we always palpate the area of pain, the region of pain last. And the reason for that is because if we palpate that first, that pain would distract your patient, and they're gonna be focused on how bad that area hurts. So when you're palpating around that area, they're not even gonna really feel that or even care, because they're already in so much pain from you palpating where it actually hurts originally. See palpation, you're looking for rigidity, means like stiffness, pain, guarding. Obviously, at this point, you guys all know what vital signs are. And chapter review. Let's take 10 minutes. I'm gonna set up the Kahoots real quick. Give me 5 minutes to set it up, actually. So I'll share again in 5 minutes. go ahead and log on, guys, to Kahoot test. All right, here we go. Yeah, so because of blood loss, your blood pressure will increase to compensate for the loss of volume. So if your patient has external bleeding, they could possibly go into hypovolemic shock because they're hypovolemic, they have low volume, right? And your body will compensate by constricting the blood vessels to jack up your blood pressure. All right, good job, guys. Next one. So the reason that over the standard telephone line is because it's the most private way of doing it without anybody else knowing about this patient's illness. So over the radio use, no, we can't do that. That's there are too many ears for that. Too many people will hear about this patient's illness, and that's gonna violate HIPAA. By calling the hospital using your cell phone, well, that could be it. Um, that's actually really good to me too, to be honest with you. Over a standard telephone line is the best answer though, because it's completely private. You don't really want to use your private cell phone at work. That's just standard for the most part, even though we all do use it, but I guess on paper, we wouldn't be using our cell phone. By calling your EMS operations line and have them relay the no, that would be letting people know that shouldn't know what's going on with your patient. All right.
Wait, so how are we going to use a landline?
Landline. So the ad question itself, I don't like the question. I can tell you that much. But like I said, these are all derived from 2015 NREMT questions. But most places do have landlines. I mean, the most Yeah, every office still has a landline. Every mall has a landline. The only place that wouldn't have a landline would be, maybe a home, but
So we use their phone, like somebody else's phone. We ask to use it.
you don't have. So there's the thing. Okay, so there's always a way we train, and there's a way you actually do things. In the medical field, I mean, out in the real world in EMT, as the paramedics and EMTs, we're always gonna use your cell phone every single time. But it's not ideal to use your cell phone, and the NREMT prefers you not to use your cell phone. So that's what it goes. That's what it comes down to be honest with you. It's just more of a what is it called? What's the word I'm looking for?
Formality.
Yeah, formality. This officially, this is how it should be done. But we all know it doesn't happen. Also, we're all supposed to have goggles and gloves. Nobody ever wears goggles unless you need them, but we always wear gloves. One of those things. I hope that makes sense. It's just one of those real life things that, yeah, on book it's like this, but really we have cell phones. Awesome. Let me see what the other answers were. So the other answers that you guys didn't choose were pay careful attention to using proper body mechanics, plan what you will do first, utilize appropriate equipment. And the best answer out of all of these is assign the highest trained person to be in charge of the move. Awesome. All right, cool. See, patients complaining of a swollen tongue, watery eyes, runny nose, rapid heart rate, indication airway may become compromised. Which one is an indication that the airway might? Yes, swollen tongue. That's obvious. We talked about that already. So, which of the systems listed below is responsible for increasing heart rate when we are nervous system is the one that a good chunk of you guys used. Yeah, so it's the nervous system. And it's really the sympathetic nervous system. That is what increases your heart rate. The sympathetic nervous system. Which of the following is a true statement regarding type 1 diabetes? Still is diabetes. Typically has a juvenile onset. Yeah, so diabetes 1, type 1 diabetes, people are born with. Type 2 is developed over time and it's because of a bad diet usually, or it could be genetics too. Patient has an isolated ankle injury. Last set of vital signs are heart rate 90, respiration rate 16, blood pressure 112/70. Those are equal. It is normal. When do you take the next set of vitals? Minutes is the best answer. answer. This patient seems pretty normal to me. Everything is within good range. So 15 minutes for a patient that's stable. Which of the following is the common reason we take a breath? The best answer is when carbon dioxide levels is too high in the brainstem. What's going to happen is your chemoreceptors are responsible for reading the level of carbon dioxide in your bloodstream. When they get high, the chemoreceptors, they'll send a signal to the respiratory center in your brain to increase respirations, to bring in more oxygen, and to take out carbon dioxide. A patient with difficulty breathing as a result of an asthma attack. He has a prescribed inhaler. For assisting patients with inhalers, what are we going to Perfect. We always have to ask for medical control direction before giving medications. Which of the following would be an anatomical accurate phrase? Nipple is superior and lateral to the navel. So the navel is your belly button. Superior means it's above the belly button, and lateral means it's to the side of the belly button. So that's correct.
Are we supposed to only have this many seconds? Because I went to click that and I didn't even have time.
Oh, was it only 20 seconds?
It's really short. Like I can hardly read everything.
Yeah.
Oh man. Give me a second. I think it might have been offset a little bit. Let's see, where's it at? Edits. Oh wow, you know what? Yeah, let's go ahead and let's see. They're all set for 20 seconds. I'm sorry about that, guys. We are on question, what is it, 10, I think, right? Let me see.
It's 11.
11. All right, so we'll do this. Let's go ahead and just let's take our 10-minute break right now. And then I have to go back and reset these to 60 seconds, and we'll start from like question 10 or 11. I'll just forward through all the questions we already did. So take a 10-minute break. Sorry about that.
If it doesn't matter to you, can we turn the sound off from right here? Thanks.
You got it. All right, just gonna wait for everybody to log in. Once everyone's logged on, we'll go ahead and restart. Just waiting for 3 more people to log in, and then we'll start. All right, here we go. I'm gonna skip to the first 9 or 10. You know what's weird? I muted it on the home page, but for some reason
It's because you didn't mute the music.
I thought
There's 2 separate mute buttons.
Oh, it's probably too late to do it right now, huh?
Yeah, yeah.
Sorry about that. All right. All right, next one we're gonna actually do, guys. So pay attention, all right? Here we go. Let me blow it up real quick. Full screen. Come on. Oh well, here you go. All right, a patient with difficulty breathing as a result of an asthma attack. He has a prescribed inhaler. For assisting, what do you do? Awesome, good job. That was the last one we did. Which of the following would be an anatomical active phrase? Awesome, good job. The nipple, so the navel, I already said it, but I'll say it again. The navel is your belly button. So the nipple is superior, meaning above the belly button, and lateral, meaning on the side. So it's above the belly button to the side. Okay, next one. What is the main problem when pulmonary edema is present? can tell me? So yeah, good job. So oxygen cannot diffuse through the fluid in the alveoli. So with pulmonary edema, we're talking about fluid that's building up in the lungs themselves, in the lung tissue. This fluid is going to go around around the alveoli, and is going to interrupt that gas exchange between between the oxygen inside the alveoli and the red blood cells inside the capillaries that go around the alveoli. Who can tell me what equipment, what type of equipment would this patient benefit from if they are conscious and able to breathe on their own? Anybody answer this one?
CPAP?
CPAP, perfect, yes. And do you remember kind of somewhat how it works?
Yeah, it's the continuous air. So like you have to be able to breathe on your own, but it just forces more air in.
Yeah. So, but down like at the physiologic level, like down like where the
It causes
alveoli.
more oxygen
So it
transfer.
pushes. Yeah. It allows for more oxygen transfer. But how does it do that? How is it allowing more oxygen transfer? What is it doing to allow more oxygen transfer? Remember?
Doesn't it push the fluid out?
Yes, perfect. That's exactly what it does. So what CPAP does is that it gives the patient like a little extra push of oxygen, like a little bit of pressure. And that little bit of pressure will push back on the fluid, and it pushes the fluid back away from the alveoli to allow for a temporary gas exchange before the fluid comes back and surrounds the alveoli. Good job. When we move up 5,000 feet in elevation above sea level, the percent concentration of oxygen in the ambient air we breathe, what happens? Decrease, increase, remain the same? What does it do? So remains the same. The percentage remains the same. What changes is the partial pressure, the amount is what changes when you go up at a high level. All right. Choose the medication the EMT can assist a patient in administering. Only one here for sure. Nitroglycerin is the correct answer. Dextrose is given via IV, so only advanced EMTs or paramedics do that. Simple form of insulin, no, we do not help anybody with insulin, at least not yet. And syrup Ipecac, we kind of, for the most part, went away from using that in general. It's everywhere because it causes a lot of damage. Patients complaining of chest pain and trouble breathing. Best reason an EMT should assist a patient with nitroglycerin. Simple enough. If the patient has chest pain and they're prescribed nitroglycerin and there are no contraindications, and this question is not telling me about any contraindications, then as long as they're prescribed it, they have chest pain, they're good to go. All right, good job. Last question. After running a stressful pediatric call, EMS providers should do what? Which one is the best answer? Between two. The correct answer was recognize they may have challenges coping with these types of calls. The other half of you chose contact a what does that say? Psychiatrist or psychologist to assess their emotional response. We'll never do that, especially not in the field. Contact a psychiatrist. Oh, I'm sorry. I was thinking about patient care. My apologies. So, see, after running a stressful pediatric call, EMS providers should recognize they may have challenges coping with these types of calls. The other one is contact a psychiatrist or psychologist to assess their emotional responses. Yeah, now that's what you would do if you do have challenges coping with. So the best answer would be this one right here. That is the best answer. All right, I am gonna share the last PowerPoint and then go from there. New share. I think it'll be this one. All right. All right, so a poison is pretty much anything that can destroy tissue, harm your body in general. If it doesn't belong in your body, we can call it a poison. The harm it can cause can result in medical emergencies. All right, so some common poisonings. Medication, the overdose is considered a poison. So some petroleum products as well, and I put some examples here. So gasoline, distillates, diesel, all these can poison the body because they don't belong in the body. Pesticides and plants as well. Like I said, it's gonna cause harm to the body. That's what a poison does. That's why it's called a poison. But it depends of the concentration and the route also does play a big part in it. As far as the age and weight and health, weight has a lot to do with how fast it's going to affect your body, and how much damage it's going to actually cause. So damage to skin and tissues from contact, that would be a poison that is absorbed through the skin. Suffocation, we're talking about inhaling a poison, localized or systemic damage to the body. So these are the routes, the 4 routes of the poisons can get into your body from. I'd go ahead and take these down, write these down somewhere. So the 4 routes that poison can get into your body, ingested being the most common one. So if you are writing this down, I would put a side note on ingested, and I would put it's the most common cause for poisoning. All right, inhaled, absorbed, and injection. And we talked about injection, how this one can go straight into the system and cause anaphylaxis much faster than the rest of these because it's going into your vascular system and it goes around your body much faster than the rest of these. So I'll give you guys a few seconds to go ahead and write these down. Different routes. All right. All right, let's keep on going. EMT's own home and squad building should be childproof against poisoning. Lock everything up, put in high cabinets. That's pretty much my recommendation. Share poisoning prevention information with members of public during school visits and community outreach. These are pictures of possible, these are pictures with the actual routes labeled next to them. So inhalation, spray like paint, cleaning fluids, injection, a drug, bee sting is another one, ingestion, anyone, drain cleaners are very acidic, rat poison, just different things that could cause poison in the body, could poison the body. So yeah, so for kids, a lot of them, they're going to just find things when they're out and about, especially your toddler age, or between, I don't know, from birth to like, I want to say maybe even 7. Some kids are still exploring and figuring out what's going on around their life, and kids put things in their mouth, you know, and they'll just chew them and eat them and not know that it's harmful for them. I know when I was like 4 years old, like I grabbed a handful of powder detergent and tried to eat it, and it was a bad idea. But like that's an example, right? That happens all the time. Adults often, well, usually it's going to be an accident or on purpose. Obviously, if it's on purpose, it's because they want to overdose and possibly kill themselves. If it's deliberate, if it's accidental, maybe they were just taking the drug, they took too much of it. It's just whatever the issue is. All right, so patient assessment, what substance was involved? So that's really important, especially down when it gets to the hospital level. They need to know what they're going up against. So taking the container, checking the label, taking a picture of what they took is gonna help out your hospital staff a lot. When did exposure occur? This is for timing. They need to know how long the substance has been in their body to understand again what they're dealing with, how far gone is the patient, how long has it been absorbing in the body, you know, whatever the substance is. ER personnel need to know for appropriate testing and treatment. See, the quantity obviously is important. So like this bulletin says here, estimate missing pills. So one thing you can go off of is the date of prescription. That should be on the bottle. And if they're 30, for example, let's say that there's 30 pills in the bottle, 1 pill per day. The bottle was just prescribed or filled yesterday or 2 days ago, and all the pills are missing. That tells me this patient took a total of possibly 29 to 28 pills, right, all together at once. So just doing that kind of math and doing some detective work is what you need to do here. Over how long a time did we talked about that? And again, like it says here, treatment varies. Poison is one of those very broad things that it could be anything and it could be taken any way. So as much information as you can get from the patient or the people around them, or even just your scene, whatever you can actually collect physically while you're in the scene will help a lot when this patient gets to the hospital. So what interventions have been taken? So when you get to the scene of the patient, if they were poisoned or they took something or they took too much of something, sometimes people try to do home remedies. A lot of times they do. So it's a good idea to get a general understanding of what the patient's family or friends have done before you get there. Just because here it says here, other home remedies, syrup of Epicac. So Epicac we don't give. We used to get that out in the field, but it induces vomiting, and people would asphyxiate from it, and also it would cause a lot of damage when the vomit would come back up, especially if it was an acidic substance. It would damage the esophagus even further. So that's why we don't use that, but you may still see some people use that in their home because they don't know any better. Estimated weight, you want to get that too as well. Again, we talked about why that's so important. And I'm going to share a video real quick on poison. Let's see, effects of mercury poison. Okay, this is just one type of poison, okay?
Hey there.
You hear
Welcome to
it?
Life Noggin. With summer approaching here in Blocko Land, I find myself constantly checking the thermometer to see how hot it really is. Once it hits 25 degrees Celsius, you better believe you can find me hanging out at the beach, getting a tan, and playing volleyblock with my friends. Now, even if this thermometer is filled with mercury, if it breaks, it won't be that big of a deal. But what about bigger quantities of mercury? What would inhaling, ingesting, or even absorbing those things do to you? What? These are just questions that I have. Don't look at me like that. High levels of mercury exposure can wreak havoc on your nervous system and your brain. One thing that makes mercury especially dangerous is that it can cross the blood-brain barrier and build up in the brain. When mercury enters your system, it causes an increase in the amount of something called reactive oxygen species. These molecules damage DNA and are strongly linked to the onset of conditions like cancer and neurodegenerative diseases like ALS, Parkinson's, and Alzheimer's. When it's consumed, mercury can start to accumulate in the heart as well as the brain. It's believed that when mercury builds up in this area, it can cause cardiomyopathy, when the heart becomes enlarged and the tissue becomes thick and stiff. This means that the heart can't function properly and it slowly begins to decline. Another key system that suffers when you ingest, inhale, or otherwise consume mercury? Your kidneys. These organs are vital in filtering blood and removing waste, but they're also a main target for mercury. The presence of this toxin has been linked to renal cancer and chronic renal disease, which leads to a gradual loss of kidney function, digestive problems, and what the Mayo Clinic calls decreased mental sharpness. None of this sounds good. Mercury poisoning has a whole slew of other effects, like memory loss, skin rash, insomnia, and loss of peripheral vision. While small amounts of mercury are generally fine, heavy exposure causes all kinds of problems for the body and mind. Interestingly, how you consume mercury and the specific type of mercury actually plays a big part in how severe the effects will be. The three main types of mercury are elemental, organic, and inorganic, and they can be consumed in different ways: drank, eaten, inhaled, or absorbed through the skin. The severity of mercury exposure varies widely among these combinations. For example, that silvery liquid form of mercury, elemental mercury, is so slippery that it'll just slide right through the stomach and intestines if swallowed. It seems like the inhalation of mercury vapors is what's most harmful, and mercury vapors are surprisingly prevalent. People typically just think of thermometers and sushi when they think of mercury, but the vaporized form of this element is also released by volcanic activity, mining operations, earthquakes, and the burning of fossil fuels. Poisons like mercury create a wide array of changes in the body depending on what the toxin is. People can suffer from seizures, fall unconscious, or enter an altered mental state. Of course, if you think you or someone else may have been poisoned by something, call 911 right away. Let us know in the comment section below what we should talk about next. We're taking suggestions for future videos. Now that we know
You share. Oh, what's going on? Patient assessment. Taking. Talk about that. All right, so food poisoning really is from food that hasn't been cooked properly. It's still raw, so some of the bacteria in the food can cause you to get sick. Nausea, vomiting, abdominal cramps, diarrhea, these are all effects, and it's because it's your stomach that's being affected really. And because of that, you're gonna get nauseous, you might vomit, abdominal cramps. Obviously, your stomach is being irritated inside. May occur within hours of ingesting food. You can't really do much for food poisoning, and it just kind of has to take its course. And most patients won't really have to go to the hospital for food poisoning. They just have to maybe be within the vicinity of a toilet, and they'll be okay and hydrate. Activated charcoal, I feel like I talked about this a lot, but all I'm really gonna say about activated charcoal is that it binds to whatever's in your stomach, whatever poison is in your stomach, it'll bind to it because of the cracks. Yeah, there's cracks in the charcoal itself. Well, it's not just regular charcoal. You can't just eat a charcoal from from your grill outside. It has to be activated charcoal. And there's so many crevices around the charcoal that it gets absorbed. The poison will get absorbed by the activated charcoal. And that's the idea. In what it does after the activated charcoal absorbs the poison, it's pretty much just going to be digested and you're going to poop it out. And the hope and idea is that instead of the body absorbing that poison, the activated charcoal absorbs it, and therefore it won't go into your system and you just poop it out. And that's the idea behind this. It's a syrup. Usually it'll come either in a little bottle. The bottle's kind of hard to explain. It'll be like a little plastic white bottle, or it'll come in a tube like glucose does as well. That's another way that it comes in. It'll come in a tube or in a little bottle. Let's see. I actually found a video on food poisoning that I thought was kind of neat, so I'm gonna reshare that. YouTube again. This guy, sometimes it's good. Oh, hold up. Okay, audio's on, that's good. All right.
Have experienced food poisoning. You know, it's like the vomiting and the diarrhea, the gastrointestinal torment that can leave you huddled miserably on the bathroom floor. But food poisoning, or foodborne illness, isn't just one thing. In fact, the U.S. Centers for Disease Control names 31 unique species of bacteria, viruses, and parasites as common culprits, but there are hundreds in total, and different microbes tend to contaminate different foods, cause slightly different symptoms, and have different incubation periods, the time between when you get infected and when you start feeling bad. So figuring out if you have food poisoning and where you got it can be trickier than you might think. The #1 cause of food poisoning in the US is norovirus, which causes around half the cases according to the CDC. Viruses are minimalist microbes. They're basically some genetic material with a protein coat, so they can't reproduce or do much on their own at all. They need a host cell. And when you eat a norovirus-contaminated salad, it finds plenty of hosts in your gut. When the virus finds an intestinal cell, it tricks membrane receptors to get inside and then hijacks the cell's machinery to make copies of itself. Eventually, those virus minions burst from the infected cell to find more victims. And at the same time, your dead and damaged cells release chemicals that trigger an inflammatory response in your body. Nearby blood vessels dilate and leak plasma into the infected tissues, which kicks off the fight against the invaders, and more chemical signals are released to attract specialized immune cells. This inflammatory response in your gut contributes to some of the classic symptoms of food poisoning: diarrhea, vomiting, and sometimes a low fever. So just know that when you're puking your guts out, at least that's your own immune system kicking some microbe butt. It's been difficult to study norovirus because until recently, researchers haven't been able to grow intestinal cell lines in the lab that it can infect and survive in. Before that, heroes among us have volunteered to be infected with norovirus so scientists could better understand it. Now they're even testing a norovirus vaccine in humans. But even though norovirus is the leading cause of food poisoning in the US, most cases of norovirus aren't from food. It's highly contagious, so infected people or contaminated surfaces can spread it too. And it's commonly called a stomach bug or stomach flu, even though norovirus isn't related to the influenza virus. So how do you know if you should blame your Uncle Carl's fruit salad for your upset stomach? Well, that takes some detective work. The simplest way is to try finding the source. Did any other people who ate the fruit get sick around the same time you did? Or did you start puking after hanging out with your buddy's preschooler who was a little under the weather? That's basically how state health agencies and the CDC approach food poisoning outbreaks too, just on a bigger scale. They have to try to trace the source so they can stop the spread of a microbe. These agencies monitor reports of illness from hospitals to look for weird spikes spikes or clusters of foodborne illness. They'll do DNA and RNA tests and perform other analysis on poop samples from patients to determine what microbe they're dealing with, from norovirus to bacterial baddies you may recognize like Listeria, E. coli, and Salmonella. Then they'll interview patients to generate and test hypotheses about where it came from. Like if most of those patients ate the same brand of alfalfa sprouts, they'll go swab that produce packaging facility to look for the microbe. When they do find the source, they try to stop its spread. The state health agency may shut down a restaurant, or the Food and Drug Administration may recall a product. But obviously, it's kind of hard for you to do that level of investigation while you're suffering by a toilet. It's not like everyone can just run a molecular analysis for norovirus. The good news is, for most healthy folks who aren't babies or old, food poisoning is a sucky illness, but you'll get better on your own, so it's not super important to know what kind of sick you are. The only way to really know what's ailing you is to go to a medical professional, which is also advisable if you don't get better in a few days or if you get severely dehydrated from all that vomiting and diarrhea. So, like, if you're worried, go to them instead of watching me on YouTube. I'm not a doctor. And you can be careful about what you eat to try to avoid food poisoning altogether. Pay attention to those recalls on the local news and wash your hands so you don't spread any nasty microbes. And if you're preparing fruits and veggies to eat raw, make sure you wash them. A thorough scrub is important even if you don't plan to eat the outside because, for instance, cutting into a melon can transfer microbes from the outer surface into that juicy middle. The FDA also recommends removing any bruised or damaged parts and the outermost leaves of any lettuce or cabbage. Plus, thoroughly cook your food, especially beef, poultry, and eggs, because heat kills any bacteria that might be on them. So next time your friend or family member is taken down by food poisoning, you can share your fun facts with them. I'm sure they'll be thrilled. But seriously, if you want to learn more about human health and nutrition, you can check out our sister channel, Healthcare Triage, at youtube.com/healthcaretriage.
All right. All right, food poisoning can occur, talked about that. Activated charcoal, we talked about that as well. Dilution, adult patients should drink 1 or 2 glasses of water or milk. So the whole idea here is that by drinking water, a lot of water is going to dilute the poison and reduce its effects. So that's the whole idea. Now, if you drink milk, that could help with the stomach settling as well, but use both. Antidotes, some do exist. Obviously, they do. They'd be not in your rig. They'd be somewhere else. Naloxone is the only one that you may have, and the naloxone is it only reverses drug overdoses from opiates. So technically, a drug overdose would be a poison. It overlaps because it's harmful to your body. So it falls in the same category as this. For inhaled poisons, carbon monoxide, so not a lot, but some people that commit suicide, they'll commit suicide by going into the garage, closing the garage, and leaving the car on, and the carbon monoxide that comes out of the exhaust will displace the oxygen in your blood system, and cause your patient to die that way. Ammonia is another one, chlorine gas. These are all gases that could be inhaled. And if inhaled for a long period of time, can cause damage and death, of course. And carbon dioxide, which we already know about. This is a big thing, yeah, so scene safety. If you ever go onto a scene and you smell something that is not normal, and you're not sure what it is, and your patient's unconscious, definitely I would not just rush in there. I would back up, look around, and if I think that smell may be toxic, I'm not going in there. I'm sorry. Nobody should go in there. Because, like, again, it comes down to your number 1, your partner's number 2, and your patient's number 3. If you and your partner are damaged, you cannot help your patient. So that's why you guys are priority when it comes to scene safety. So this patient must have inhaled something. They have a vehicle here making it seem like there's some kind of gas or something, and he's being carried out. Now, this is pretty normal right here. We guys see they'll have the SCBA, self-contained breathing apparatus, and it's obviously supplying them with air. And for a situation like this in a rig, you're not gonna have this kind of equipment, so you will have to call the fire department most likely for a situation involving gas. And I'm gonna pull up another video that discusses or goes over inhalation. It's a cop that goes on scene where a patient is down, and it's due to a gas, but the police officer unfortunately doesn't take scene safety into consideration, maybe because he wasn't trained, so that could be it too. But he actually ends up dying from it, and you guys will see it. And then just pay attention to the firefighters as they arrive and while they're taking care of this cop. Okay, that's what I want you guys to really look at.
What's the ETA on fire and ambulance?
1222 Effingham, 10-4, Ken Mundy Alma Fire Department advises ETA 5 minutes, ambulance 5 to 7 minutes.
2210-4, advise ambulance and EMS to expedite. I'll be out of the car checking victims.
2210-4. 61 Effingham, 1020.
You guys see this gas, right? But again, it's a medical
professional. 25 with 22 at Dixon Gray Road, assistance with 1052.
What you're hearing right there, that's the patient breathing. SCBA's on. The rig back here, facing away. Exactly the way it should be done for the most part. Maybe a little bit further away than this, but. Right now is they're getting the hose ready. They're going to use the hose as a barrier for the smoke. And what they use is called a wide V angle, and it makes the hose water come out kind of like a shield. You can still see right now that it's got to create that shield barrier water with the wide angle. And they're going to be the patient now. But on top of that, you have this right, guys. So we'll go ahead and stop there for tonight. It's almost 10 o'clock. Any questions for me? No. All right, we're gonna go over chapters 24 and 25 tomorrow. It's hematologic and renal emergencies and bleeding and shock. So if you guys don't have any more questions, good night.